vision because of uncorrected refractive error. And I'm sure many of you on the joining the webinar probably wear glasses or contact lenses. I know myself, I would not be able to function if I didn't have my visual correction, and I'm sure that's true for many of you. And then I think also thinking about when most people start wearing glasses for distance, that's usually in the school-age population. So again, thinking about myself, I actually started wearing glasses when I was 8 years old. High resource setting where I had access to an eye examination and a pair of spectacles. But when we look at the developing world context, what we see is that there are issues both in supply side issues as well as demand side issues. Supply side issues, there's just not enough human resources. There's just not enough optometrists or ophthalmologists within many of these settings. And even where you do have optometrists or ophthalmologists, we know 67% of them are actually located in capital cities. There's also a lack of diagnostic equipment in order to test the eyes to detect the refractive error, as well as affordable, quality, and acceptable spectacles. So that's all supply side issues. On the demand side issues, we know that there are stigma around the wearing of spectacles, as well as awareness of benefits. For example, parents might think that if their child wears glasses, it might actually hurt their eyes and weaken their eyes instead of helping their eyes. So that's something we see, as well as, of course, the bullying and, being called four eyes, etc., that can also impact why children may not want to wear glasses. And the cross-cutting issue is, of course, the financial, when we look at the prohibitive cost of spectacles, as well as competing priorities for financing that we'll talk about a little bit later. Next slide. So I just want to point out that school screening programs are not new. And, in almost every country, there is some school screening happening in one form or the other. However, these are often uncoordinated, where it may not be linked in with the Ministry of Health, Ministry of Education policies and plans. And often they're ad hoc. So you may have a donor come in with a pot of funding to carry out a one-time only school screening where a team might go out, examine some kids, give out some glass return. That with them, as they're growing, their eye grows as well, and their refractive error changes over time. So these children need to be followed up on a regular yearly basis.
Imran, I think we lost for a second.
Okay, so I was just talking about how school screening are uncoordinated, how they're often not tied into the government's plans or priorities, as well as ad hoc. So they're not planned in a systematic manner in terms of delivering the services, follow-up, and oftentimes these are not standardized. So in terms of the prescribing guidelines or the distances, or a program of school screening may look very different, even within the same country, within different regions. And a critical issue is the lack of sustainability, that oftentimes school screening programs are funded by an external, external funding source, where an NGO may come in with funding to carry out vision screening on a one-time basis, and after that project finishes, the school screening programs also tend to end. Next slide. So the overall objective of the SHIP program was to enable our government partners to actually systematize good practice, evidence-based school health within their sector policies and practices, and really build in school health programs into their education sector plans in order to ensure that these programs are not only sustainable, but can also be scaled up. And again, we use these two school health interventions, vision screening and deworming, as models to show that an integrated way of delivering school health can both be effective as well as efficient in order to build the government's capacity to scale up these approaches. So that was the overall objective of the SHIP program. And what we hope is that we've created a platform and a foundation with these two model interventions that other health interventions can be integrated within this into a school health and nutrition package that can be integrated into education sector plans. Next slide. So I'll go through briefly the overall approach to implementation that we used within this integrated program. And the way that we carried it out was the first step was really engaging and getting the buy-in of the government partners. So it was really sitting down and raising the awareness of not only the Ministry of Health, but also the Ministry of Education. And in many ways, it was putting the Ministry of Education in the driver's seat in order to plan and implement these programs in support and collaboration with the Ministry of Health, as well as other development partners, including local education donor groups and other NGOs within the country. So that was really the first step, was that capacity building exercise that also incorporated having national workshops to really raise the issue of school health and nutrition and get into some of the specifics about deworming and vision screening, as well as the model that we were proposing. At that stage, we also looked at joint planning, so working with the Ministry of Health, Ministry of Education, to really sit down and map out the districts and the regions within the 4 countries that we would be able to implement this sure that we have the infrastructure and the referral basis to support this system. The second stage was the training exercises. So what we did was we had an integrated training package, whereas we trained, we carried out a train the trainer program where the trainer was, we used the standardized guideline approach to train the trainer on both the vision screening and the deworming interventions. And this training was cascaded down to teachers to train them on both of those interventions in about a 2-day training package. At that point, during the implementation, the deworming tablets were distributed to the teachers would collect the names of those students, and then optometrists or refractionists from the Ministry of Health would come to the school and carry out refractions, and were able to give glasses on the spot with an innovative new system where the child would be able to choose from a variety of frames that were in different colors, different styles, and the power of the glasses, we were able to clip in those because we had lens blanks that were able to fit into these different colors, different styles of frames. So therefore, we were able to treat the students on the spot. And if a child needed to be referred, we had those referral networks into the closest eye unit.
No.
Next slide.
No.
And I just want to, I do see that there are some questions coming through, and actually some very good questions coming through. So what we're going to do is we're going to leave time at the end of the presentation to address a lot of these questions and a lot of these issues that are coming up. So in terms of the approach that we used, what we believed is that in order for the teachers to carry out the vision screening, we need to make it as simple as possible. That, you know, in fact, I do see a comment about what are some of the potential and limits of having teachers provide basic health screenings. Well, one of the main limitations is that often teachers are overburdened with the these additional responsibilities that they have in addition to their teaching responsibilities. And we did not want to make teachers mini eye doctors here. What we wanted to do is make it as simple as possible and as quick as possible for them to carry out the vision screening. And what you'll see on the bottom right side of the slide is the simplified vision screener that we used. So that was just a row of letters and a pass-fail criteria. And so therefore the teacher didn't have to even have the child read an entire eye chart, which takes time and is often quite difficult. It's actually more difficult than it seems to get accurate readings. So it was really a simplified vision screener. You know, another thing that we tested was these ready-to-clip spectacles, and you'll see that in the bottom left point of the screen. And what was really innovative about this model, it was done through one of our private sector partners, and we got a price point of these at $2 per pair, so definitely affordable, and these were actually high-quality glasses. And I'm not going to go into the technicalities of that, but would be glad to discuss this. We also, you know, incorporated the use of the tablets, and we had and the training and the implementation was done in an integrated fashion where the students who received the deworming also received the vision screening, and we also developed standardized guidelines and also development of materials to help with communities' engagement and sensitization. Next slide. And just this slide here, just some of the standardized guidelines that were developed, which are really how-to guides in terms of how to create an integrated school health program, as well as the technicalities behind carrying out a school-based vision screening program, as well as deworming program, and teacher's handbook to help also utilize the school as an effective place to transfer health messages as well. So these guidelines were developed as part of this project, and they were used as part of the training materials for the teachers, and were refined, you know, after they were tested in the field. And these are actually available on a multitude of websites. So we definitely encourage you. We'll tell you how to access these, but they are open source, and we do encourage you to use these. So next, I'm just going to learning that we got.
Sorry, Imran, I missed you there. Did you just hand over to me?
I did, yes.
Okay, fantastic. Thanks so much for that, Imran. And yeah, just to say that the next few slides, we'll be talking a little bit about yeah, our learnings from the program as a whole, and what we took out from each country. And it was, as Imran mentioned earlier, we implemented over 4 different countries, and that really gave us a snapshot and a wide kind of spectrum of different situations to see kind of what was working, what was not working, and how to improve that engagement by the governments themselves. So from the pilot interventions overall, as far as implementation went, the governments with support managed to train 476 teachers across 158 different schools. 57,434 children were screened, were vision screened by the teachers, and 47,106 children were dewormed, provided deworming tablets for STH infections, and 1,017 were provided with glasses as a result of that vision screening, which provides a total refractive error prevalence of 1.7%. So that's just a snapshot. And as mentioned before, this was just a pilot implementation phase of the integrated intervention to trial with the government of what an actual integrated program would look like. So just what we've done is pulled out some of the very key findings from each of the 4 countries of what really was working in each situation. So in Cambodia, we benefited in a large part there that Cambodia was actually the recipient country for an earlier pilot phase program. And as a result, that program, vision screening, had already been taken up by the Ministry of Education, Youth and Sports there, as a result of the fact that the vision screening provision of spectacles to students had visible impacts on education. So that was already in the work plan. And in addition, Cambodia also had a very large and successful national deworming program as well. So the key challenge here in Cambodia was really how do we integrate these ongoing programs in order to realize the efficiencies of an integrated training and integrated intervention and integrated monitoring. But I think one of the key takeaways that we found within Cambodia, the success of the program, was really that the government was really in the driving seat from the very beginning. They took charge of the financial management of the funds. They really kind of developed that plan for implementation, and they supported the program and actually embedded it into their education sector plan. So that was all very good, and as a result of the activities that were going on in Cambodia, it led to an increase in the understanding of the costs of the project, and we got some cost effectiveness information from that as well. In Senegal, what we found there was the existence of a school health department, and it was already the program was already relatively organized, engaged, and decentralized. So that led to a huge amount of ownership at the local level and control of how they implemented and designed. In addition, there was a lot of evidence about where the parasite prevalence was highest, where parasites were a particular problem, and so the resources could be allocated. And that was a huge success for the uptake of the program at the ground level as well. The coordination and support from the Senegalese Ministry of Education was very impressive. The education sector policy considered school health and nutrition as a support, and understanding really helped further the program. And in addition, what we saw there was the eye health as a whole, but including refractive error indicators, were getting integrated into the national health reporting platform as well. So what really the outcomes in Senegal was really seeing the genesis of a very much an integrated implementation plan. In Ghana, the existence of the school health education program, a department dedicated towards school health and nutrition, was a large part of the success there. And Sept was provided with the driving seat behind designing and developing the program and coordinating all the partners on the ground. As well, they already have a school-based deworming program. that was but really the key thing in Ghana that led to the success was in 2016, a year before, they developed a countrywide policy that focused really on the early detection of disability, health promotion habits, attitudes and values. So having that and having the government's kind of pushing behind this really did lead to the uptake and the easier integration of these two activities. And what happened in Ghana that was quite lovely to see was that as part of that, the detection of disability policy, we also managed to integrate not only vision screening but hearing impairment as well. In Ethiopia, we saw an ability to build an existing integrated program, and which was already being run as a pilot, as a moved up at a much larger level into the education sector. We also had the ability to work with the Ministry of Health's national deworming program that was nationwide. So really we had that integration of the training of the teachers into a single session, realizing the efficiencies that were there. There was also a huge amount of existing interest to conduct vision screening activities in the schools. This was evident when we did our very early stakeholder mapping, that there was actually 3 different vision screening programs being conducted by different departments, including the Ministry of Health, as well as the disability department within Ministry of Education. So what we managed to do is really kind of get these two to coordinate and to avoid the duplicity of kind of repeating activities, and really forging further linkages between the health sector and the education sector, developing an open dialogue between all stakeholders, and really capitalizing on the existing infrastructure that had been within Ethiopia. What else we found in Ethiopia was a competent and engaged workforce at the local level really supported the successful training and rollout of the program. So overall, the key learnings that we pulled out across the board were really that schools are an effective platform for delivery, but they really require the underlying structures, the policies and guidelines, which is necessary for the coordinated scale up of these programs. And without those structures, the program will not go to scale. And as well, in order to embed school health and nutrition as part of education sector plans, to mainstream it, to develop that sustainability, the School Health and Nutrition Department and the Ministry of Education really need to be part of the development of those plans. And we showed that in many of the countries that we were working in. The second learning is that collaboration between the Ministry of Education and the Ministry of Health is vital, and it can lead to harnessing additional platforms and partners. And countries may also have streamlining. For example, when I mentioned in Ghana that there was already a disability policy there, and that we can stretch that integration out further to do hearing impairment. And in disability and inclusion sectors also encompass can be encompassed by health as well as education. So the platform may already be in existence, it's just a matter of identifying it and harnessing it. The third thing that we found was integration can be a more efficient use of time and resources than multiple vertical interventions. And that was something that we were quite aware of, that having that realized into action and being shown at the ground level, at the implementation level, was very crucial to having these activities be absorbed by the ministries, in particular by the Ministry of Education. The existing policy, systems and infrastructures should be used to build capacity in the education sector for long-term sustainability. Underwriting these activities are important to ensure that the structure and guidance, as well as the continuity and support, is there to continue that programme. and that's what happened in Ghana in particular was SHIP supporting an existing policy and aligning with that to ensure that the program had a wider reach on all sides. And finally, the fifth thing was that school health and nutrition must be accessible and inclusive to all. And really, it's very key that this doesn't include just the non-enrolled and the enrolled children, the out-of-school children, but that those children who are disabled in whatever manner are provided with the tools that they need to be able to access the education. Yeah, I was going to in Ethiopia, the third vision screening activity was in the form of resource centres, which were these focalised centres which were being provided with additional resources for further screening. And that was really Ethiopia's mechanism for being able to utilise resources, being able to identify those students who may need further support, whether it's a hearing aid, whether it's a pair of spectacles, or whether it's further support with their actual learning abilities. And that was quite key and very clear to us that many of these countries are already attempting to make sure that their school health and nutrition and their education is inclusive, and it's just a matter of making sure that this is all harnessed and utilised. So those are really our 4 experiences from the 4 different countries. I'm sure you have more questions for us, which we're very happy to, or it is our contact information as well. So thank you very much.
So I do see that there are some questions that were brought up. We can go through some of those. So I think one of the questions that is quite an interesting one is around the cost effectiveness of this approach, and that is a critical issue, because one of the overall objectives about utilizing an integrated program, well, it's twofold. One is that we felt that by running an integrated approach, we would be able to increase access to both of these different interventions. So in some ways, actually use it to create a synergy by which we were able to deliver both vision screening and deworming at the same time. So that was one, about increasing access to both of these interventions. The second one was around the cost effectiveness, that we felt that there were definitely ways to increase the efficiency of the system. Conventionally, we've noticed that deworming and vision screening, as well as other health interventions, occur in isolation, where you might have one group coming in during one period carrying out the deworming. A few weeks later, a few months later, a group might come in, pull the teachers out, train them in vision screening. A few months later, maybe the same thing would happen around hearing. So what we felt is that instead of having all these ad hoc, uncoordinated health interventions, that by integrating it, we build better efficiency in terms of the service delivery itself. Another point of efficiency that we used was in utilizing the teachers to carry out the screenings. So instead of having an ophthalmologist or an optometrist go through and carry out screenings, it was really training the teachers to carry this out. And I would say that within deworming, for the most part, that this has been something that has been accepted, having the teachers carry out the deworming, except in a few exceptions where this does not occur. However, with vision screening, we really wanted to use this as our model and really advocate for this. And there is a number of studies that have been published that have actually demonstrated the effectiveness of using the teachers to carry out the screening. So it's really looking at that efficiency gains in terms of that skill mix by having teachers carry out the screenings and identify those children who actually needed further evaluation. And then, of course, we tried to create efficiencies within the system by using this ready-to-clip spectacle system instead of having to have a custom-made spectacle or or bespoke spectacle, which not only adds much greater cost, and the costs we were looking at were around $10 to $20 for custom-made spectacle, but then there's also the time to, these spectacles would have to be made at a workshop, be shipped back to the school, or the student would have to go to that workshop to pick up the glasses. So there's both direct and indirect costs. So we felt that by utilizing this ready-to-clip system at down at a $2 price point, we would be able to deliver those spectacles, at the same time at the point of service. So it's really looking at those different system of efficiencies to demonstrate the cost effectiveness. In terms of carrying out the actual study of the cost effectiveness of this integrated approach versus a non-integrated approach, that's really the next step. So within this project, we wanted to show that it can be done, and schools can be used effectively to carry out these interventions. But really the next phase, which is something that Sightsavers and PCD, I would say we kind of have in process, is that we are going to be looking at these costs of an integrated versus a non-integrated system and be able to put some numbers behind that. And I think, some of the other issues with that is around the teachers themselves, about having them carry out the basic screening and referrals, as well as how do we make sure that the children are not cheating. So it's really looking at how do we know that teachers can be used effectively within the vision screening. And I guess in terms of if the children are cheating, I guess it's one of those where within the vision screening itself that they wouldn't necessarily be able to cheat to give a better result than their vision is actually showing. However, if they purposely fail the test, then they would end up getting put on that list of children who fail the screening, and then the optometrist would come in and evaluate those children in addition to, basically all the children who are listed as failing the screening. So it's not that these children would be given glasses if they don't need it, but rather they would be referred for the further evaluation. And I guess there's that question around the teachers providing basic health screening and referrals. Well, there are, we talked about some of the advantages, both in terms of cost as well as effectiveness, but really some of the challenges behind that we've noticed is really how do you incentivize the teachers to carry out the screening? Because again, it is something that is built into their responsibilities, and oftentimes teachers are already overburdened. So what we did within this project is the teachers who were involved with the screening, we actually gave them an eye examination and dispensed a pair of glasses if they needed it. So that did actually a few things. One of the advantages with that was having the teachers, basically see the value of the vision screening by having themselves having their own vision screened and realize the importance of correction. So what we actually noticed was that several of the teachers actually needed glasses themselves. And by correcting teachers as part of this project, that had two benefits. One benefit is, of course, that if a teacher has improved vision, then they can do their job better. Because, you had teachers who were struggling to grade students' papers, or it's hard for a teacher to maintain discipline if they have a vision problem and they're not able to see clearly at the far end of the classroom. So it was making them more effective as teachers, as well as they were serving as role models for spectacle wear themselves. So the children would see their teachers wearing spectacles, and that would, raise awareness among the children as well, and hopefully reduce some of that stigma discrimination. And also create a sense of incentive for the teachers to be engaged in this program. Because what we didn't want to do is we didn't want to, give financial incentives, because again, we know that something like that, then you might actually create, it might be counterproductive, because if you're incentivizing the teachers financially, when you stop those financial incentives, then they would stop the screening as well. So there is that risk. So that's something about some of the risks by using, or some of the challenges with using teachers, but also how we tried to mitigate that within the project. So Laura, maybe I'll turn over to you to see if you want to add anything to what I said, or if there's some new questions that are coming up that you might want to address.
Yeah, I see a question from Sung there about the differences, the discrepancy between the numbers of children who are vision screened versus the number of children who were dewormed, and that was just sort of kind of an accumulation of multiple countries where not all the children wanted to be dewormed. Of course, you can't provide deworming if by force. As well as that, I think what ended up happening was, in certain situations, due to the kind of force outside our control, the deworming was actually administered on the same day as the vision screening, and a lot of the times somebody from out of school, a non-enrolled child, would have come in for the vision screening to get a pair of spectacles, and they knew that was an issue, and not been provided with deworming drugs on that same day. It was unfortunate that as far as an initial rollout, we are hoping that those kind of initial hiccups can be smoothed out as we go forward. I also see a question from Mahimi about the outcomes in terms of participation or educational health status. It was actually outside the remit of the program to really study this in detail, but certainly in terms of the initial pilot that we did within Cambodia, there was definitely an uptick in kind of attendance and participation, actual kind of participation in a classroom level within those children who had managed to be screened. We also had a lot of kind of feedback, verbal feedback through just general discussions in the course of monitoring the program, and comments from the teachers of how they're seeing the difference, either in themselves, if they were provided glasses, or with the students who were then able to participate in school more fully. I think it's a bit harder, particularly on the levels of the scale of the pilot program, to actually see the change with the sample sizes that we were doing to a significant level. However, we all know that if you can't see the blackboard, you won't be able to participate in school, and there's been many studies that have been done in terms of the dropouts that are caused by that, or through ill health, poor health, as a result of parasitic infections. In terms of the uptake of the guidelines by the governments, they were very much done in collaboration with the governments in many situations. They haven't, at this point, they're still awaiting to be translated so that we can scale them down, particularly cascade them down, particularly the teachers' manuals. Was thought to be something that would be quite handy on a ground level, and at the kind of the national level, the regional levels, the kind of guidelines for how to actually structure and implement and design either a vision screening program or a deworming program, and then on the other level, how to actually work to make sure that the efficiencies of school health are really realised, so that teachers aren't being pulled out continually for various trainings, and various different pockets of money are being used to get them to mobilize these people for these trainings is happening continually. So that was certainly the potential for that is seen there quite a lot. So I see a couple more questions. Why was there such a resistance to the deworming?
Well, Laura, I think it's also when we look at the difference between when we break it down by country, actually one of the main problems we had was actually within one country. And that was within Senegal, where I think there was a lack of coordination with the national deworming program, and there was delays within the national deworming program. So what we did within the SHIP project is we didn't want to create kind of a vertical system in terms of the deworming. So we really aligned ourselves with the plans for the national plans. But what ended up happening in that one country was that due to delays within the national deworming program within the pilot region, that within the life of the project that these children were not dewormed at the time. I mean, we were assured that they would be dewormed at a later point, but ideally we would have the two interventions occurring at the same time and not having these delays. So, I guess one of the key learnings on that is around the importance of that coordination and to make sure as well that the deworming, drugs are being delivered on time in a well-coordinated system. And that really didn't happen to the level that we wanted in Senegal. So I think that's why we're seeing kind of that critical difference between the vision screening and the deworming, especially in that context. So I see there's a question from around what are the next steps. Well, one of the next steps, some of the next steps are really looking at the costing, because we find that the costing is critical. That if we want to be able to go to governments and have them scale up or definitely adopt this approach, that we need to be able to put costings behind it, and we need to demonstrate with the numbers why an integrated system is a lot more cost efficient than using a non-integrated system. So one of the critical next steps is the costing study. Another next step is really around the dissemination of both the learnings as well as the guidelines. So it's using these countries as model countries for the region in order for these countries to share what their learnings are within the region, as well as offering support to the pilot countries on how to scale up these programs themselves. So it's going back to these countries and working with them to both discuss the learnings, but then also look at how can we mobilize further resources in order to scale these up and to continue these initiatives within these countries. So I would say that the next steps are within those three areas: the costing, the learning, the regional sharing of learning, as well as the support to sustaining and scaling up these initiatives.
Are you able to hear me now?
Yes.
Oh, perfect. Thank you so much, Imran and Laura, for the sharing the findings from your innovative pilot on an integrated program for school deworming and vision screening. Oftentimes one hears a lot of criticism, especially for the vision screening, when it's not followed up by the referral or the action needed for those who have refractive error problems. And it's good to see that you've found a solution in one, providing the glasses then and there, and also combining it with an existing national program. I think there will be more questions around the cost effectiveness. Also, when you look at multivitamin supplementation, and if that is something that could be combined as a service. So we look forward to hearing from you on the findings from your cost effectiveness studies. I'd like to take the next minute or so just to thank our presenters and Alicia, my colleague, for organizing the webinar, and for all of the participants for staying for the hour to listen to this interesting presentation. I'd also like to announce that the webinar for next month will be around mental health and will be presented by Dr. Vikram Patel and facilitated by Doug McCall from the International School Health Network. We'll be sending out more details on the dates in the coming days. We'll also be sending you the recording from today's webinar, which really commemorates the upcoming Global Day for Sight, World Sight Day on 13th of October. So I thank you all, and we'll be in touch soon again.
Thank you so much.
Thank you.